So welcome back. My name is Aristea Galanopoulou from the Neurology department. We heard earlier how proud we are in the Neurology for what Fatima and Jules are doing for the Tuberous Sclerosis Center. And it's my distinct pleasure today because I have the opportunity to introduce someone who is actually a role model for what Fatima and Jules are trying to create here in Bronx. Elizabeth Thiele, I know her. Actually, first I knew about her when I was trying to dig into the literature about infantile spasms, the natural history of this epilepsy syndrome in patients with tuberous sclerosis. And her work in the field of tuberous sclerosis is a kind of text reference. Whenever we need to know something about natural history, what our patients are doing, how do they respond, what do they need, Elizabeth's papers are the main source of information. She was trained in Johns Hopkins, and she currently is a professor of neurology at Harvard. She's the director of the Pediatric Epilepsy program there, and also the director of the Herscot Center for Tuberous Sclerosis at Harvard. She's very distinguished. She has multiple publications. We heard some of the work that she has done from Dr. Roberts, and she has seminal papers on natural history of tuberous sclerosis, and we're going to hear her work today. She has been awarded several awards, including the Manuel Gomez Award from the Tuberous Sclerosis Alliance, the Infantile Spasms Award from the Child Neurology Foundation, and I'm looking forward to hear what is new in the field today.
Thank you, Aristea, and it's also quite an honor for me to be here, not only talking about TS, but also for the person that the conference is named for. Throughout my career, when I was a resident and on, Isabelle Rapin was a superhero to me, someone I have always looked up to as being wicked intelligent, extremely bright, passionate about neurology, very eloquent. And also a woman. So for particularly being a young woman in training, she has been a role model. One of the times I saw her was actually when we used to have oral boards. I walked into my oral vignettes, and there was my superhero. So at first it was celebrity awe, and then I was terrified, honestly, that here was a person who was going to be giving me my oral boards, but I did pass. But again, it's an honor to be here. So what I'm going to do today is first look at what the natural history of epilepsy and TSC. As we all know, we'll see it's a very common disorder in this condition. And then I'm going to look at work we have done over this past several years, and other people have also been very interested in this, is what is the relationship of epilepsy and TSC to the other aspects of the neurologic phenotype, including the cognitive profiles in TSC, autism in TSC, and also the TSC-associated neuropsychiatric disease, which is now referred to as TAND. And then at the very end, I'll kind of come to could there be or will there be a possible role for cannabidiol. As probably all of you know, over the past several years, there's been increasing interest in the possible role of cannabis in the treatment of epilepsy. And so I'll talk about some of the work we've been doing that is ongoing of looking at it in TSC. So first, looking at the natural history of epilepsy and TSC, and Kat Hsu did this when she was my TSC fellow many years ago. We looked at the population of folks we'd seen at the Herscot Center for TSC, which takes care of both children and adults with TS. And we found that in our population, 85 had had a history of seizures, and all but 2 developed epilepsy. So this was important for me because whereas in many times we don't start an anticonvulsant medication after a single seizure, I think in the setting of tuberous sclerosis it seems very reasonable to, since the majority of people, by far the vast majority of people, will go on to develop epilepsy. We also saw, as we expected from the literature, that the majority of people have onset of epilepsy the first year of life. And we also found, as suggested by the literature, that over a third, or approximately a third, of children with tuberous sclerosis will develop infantile spasms. Only 2 in our population has spasms as the only phenotype. The majority also had focal epilepsies. And of those that developed infantile spasms, 2/3 went on to develop refractory epilepsy. We also saw that in the majority of our population, there was more than one seizure type, and many of these kids have 3 or 4 or 5 different types of seizures. We also saw, as we expected, that there is also a fairly high incidence of Lennox-Gastaut in the TS population. 6% of our population, we could say, had definite LGS based on not only seizure type but EEG criteria, but another 21% were probable, and the majority of those had a history of infantile spasms. Then looking at kind of how effectively is epilepsy and TSC treated, we found that about 2/3 of folks have medically refractory epilepsy. So as you know, that's twice the percent of refractory epilepsy in the general population. But also really importantly, we found that a significant number achieved remission. So 34% of our population achieved remission, ranging from childhood to adulthood. A third of those had refractory epilepsy, often highly refractory epilepsy, and almost 40% of individuals were off anticonvulsant medications at the time of their last visit. So as we discussed with our patients, although they'll have tuberous sclerosis as a lifelong condition, they'll not necessarily have epilepsy and the need to be on anticonvulsant medications. We then also looked at the affective genotype, because a lot of what we're trying to do is can we correlate any aspects of the TSC phenotype to the genotype? And we found that infantile spasms were more common in those with the TSC2 mutation. Interestingly, we've gone on to look not only at which gene is mutated, but where in the gene and what type of mutation, and we found that central TSC2 mutations have a lower risk of infantile spasms than mutations elsewhere in the gene. Looking aside from spasms at the percent with epilepsy and refractory epilepsy, we did not see any difference between those with a TSC1, a TSC2, or no mutation identified. However, the group with no mutation identified, many of whom we know now are mosaics, often low-level mosaics for a TSC1 or TSC2 mutation, were more likely to achieve remission. So how do we treat epilepsy in TSC in 2006? Anticonvulsant medications continue to be the first-line therapy. Seizures in TS by definition are focal onset or partial onset, therefore most of our medications could work. There's anecdotal experience on the efficacy, particularly of some of the newer drugs, but there have been no controlled comparison trials. Vigabatrin, however, I think is clearly the drug of choice for infantile spasms in TS and accepted as such. However, as you know, there's possible retinopathy associated with that, and also the possible ability of MRI changes in the deep gray nuclei, which is of uncertain clinical significance. But as we said, 2/3 of folks with TS will develop refractory epilepsy. So what do we have as options when those medications don't work? Dietary therapy, vagus nerve stimulation, and epilepsy surgery all play a very important role in the management of seizures. And then kind of as Pete alluded to, what about the mTOR inhibitors and the results of EXIST-3 trial? And Mike is going to cover that in his talk. And then, as I said, I'll come back to the possibility of cannabidiol. So just looking really quickly at dietary therapy and its efficacy in TS, years ago we published with the folks at Hopkins our combined experience showing that the classic ketogenic diet is as effective in TSC as other etiologies of epilepsy. And we also looked at our low glycemic index treatment, which I talked about here a couple weeks ago. At the time we looked at this, we'd had 15 individuals with TSC on our LGIT diet. Largely children, highly refractory epilepsy, and then a range of time on the diet. And what we saw was that 2/3 or 10 out of the 15 were responders. 10 out of 15 had a greater than 50% reduction in seizure frequency on low glycemic index treatment, including a few that had highly effective treatment for them. And then this is just one of the kids we've had on LGIT. He's a 23-month-old boy, lives in New Jersey. His seizure onset was at 6 months of age with infantile spasms, and then 8.5 months of age, he had onset of focal seizures. By the time we met him, he had been refractory to 3 medications, and he was scheduled for invasive monitoring and epilepsy surgery at NYU. He was on oxcarbazepine and zonisamide and having 3 to 4 seizures per day. He came to see us for another opinion. We said, it's great that your seizures have been lateralized. It's great that surgery is an option, but since that's 4 weeks from now, why don't we just try the diet? So he went on our diet and was seizure-free 20 days after starting the diet, tapered off of his medications after 11 months on the diet, tapered off the diet after 16 months and having a normal EEG. And I got the cutest letter probably ever from Howard Weiner at NYU saying, Dear Elizabeth, I would agree since he's no longer having seizures that epilepsy surgery is no longer indicated. He now has been seizure-free for well over 4 years, off the diet. He's normal precocious development and on no medications. And his father, his first day of kindergarten, sent me a beautiful email and a picture of him with his backpack and his lunch going to kindergarten, saying that as he drove away from dropping his son off, he had to pull over because he had tears in his eyes that he didn't think that day would ever be possible. So diet can be very effective. Then looking at the vagus nerve stimulator, and we have looked at this as well as others. There's limited experience, but likely effective, although not a cure for seizures in TSC. In all of this different reports on this, at least 50% have had a greater than 50% reduction in seizures. And interestingly, in addition to seizure control, there's also possible improvements noted in quality life and adaptive behaviors. Then epilepsy surgery, I think there's increasing experience, comfort, and success, and also a possible cure for epilepsy and TSC. But the questions remain who, what, when, where, and why. And also there's no consensus yet on what is the ideal way of identifying the hot or epileptic tuber. Is it EEG? Is it magnetoencephalogram? Alpha-methytryptophan PET? Co-registration of MRI, PET, and MEG, SPECT scan. And then there's always been a concern, what about the other tubers? If a tuber is causing seizures today, who's to say a tuber won't start causing seizures tomorrow? But the nice thing about being in the MGH and taking care of a lot of adults with TS is I can see long-term follow-up. And I have two women, one who had epilepsy surgery in 1957, one who had epilepsy surgery in 1961. Both have been completely seizure-free since their surgeries. So surgery can be a cure or long-term control of seizures in TS. But there are many things about epilepsy and TSC that we don't understand and we need to know. We still do not know why people with TSC develop seizures. We think it has some relationship to the tubers in many. We think that the tubers may be epileptogenic, or could they be irritating to the normal neighboring neurons? Are all tubers created equal, or are some more epileptogenic than others? Clearly that's true, because an individual may have 50 tubers, and yet the seizures appear to come from one. Or could epileptogenicity be related instead to diffuse and or more subtle cortical or subcortical abnormalities, like Pete suggested, that areas of the brain aren't distinct tubers still are not completely normal? And then there's been a lot of interest, particularly with the involvement of the mTOR inhibitors, are particularly individuals with TSC at risk for seizures? And in Europe now, they've just fully enrolled in a trial called Epistat that's enrolling babies with TSC where they develop abnormal EEGs prior to the onset of seizures and treating with vigabatrin. There's a lot of discussion about using mTOR inhibitors as a preventative treatment in TSC, and we are now enrolling babies identified with TSC prior to the onset of seizures in a ketogenic diet trial to see if that could be disease-modifying and prevent the onset of epilepsy. But I think it's not just the seizures that people with TSC live with. And so what we'll go over now is the presence of refractory epilepsy and infantile spasms in TSC is significantly associated with cognitive impairment, autism spectrum disorders, and psychiatric disorders, including self-injurious behaviors as well as sleep disorders. And therefore, I think it's really crucial in individuals with TSC to control their epilepsy. So first, several years ago, we looked at the cognitive profiles in individuals with TSC, and this is very similar to work that's come out of the UK by Patrick Bolton, in which we saw if you look at the neurocognitive profile by formal neuropsychological testing of people we follow, you get a bimodal curve, and basically about 50% of individuals have normal cognition, and 50% have some degree of intellectual disability. If you look at those with a higher IQ, the variables that appear to play a role in that is older age at seizure onset. So of our patients with seizure onset greater than 2.5 years of age, none of them had an IQ less than 70. And then also if there's a family history of TSC is a positive variable for higher IQ, although that is also a higher number of people with TSC1, and a lower frequency of infantile spasms and refractory seizures. If you look at variables associated with lower IQ, what we found were pertinent were current seizure activity, refractory seizures in mixed seizure types, and a TSC2 mutation. So I don't think that it's just the epilepsy alone that causes or leads to the cognitive impairment, the autism behavioral disorders, but I think it clearly can modify the phenotype of all of those. Adam Numis, when he worked with us, was particularly interested in autism and TSC. And in the literature, there's quite a range, ranging from different populations of 16 to 60% of individuals having autism. So we also looked at this in our population with a single neuropsychological psychologist evaluating all of the individuals. And we found that about 40% of individuals have autism. And those with autism were significantly more likely to have a TSC2 mutation, significantly more likely to have a history of infantile spasms and refractory epilepsy, significantly lower IQ, not more likely to be male. And in the general autism population, males are 4 to 1 to females. In our population, it was 1 to 1. And we did not see a significant difference in TSC-related brain involvement. Adam looked very closely at the neuroimaging features of these individuals. And again, we did not see a significant difference between the regional distribution of the largest size tuber or of the overall tuber burden. However, there was a trend for those with autism to have their largest tuber burden, but not the largest overall tuber in the left temporal lobe. And we did not see a difference between cerebellar tubers, calcified tubers, radioglial bands, or subependymal nodules. Now, many people, including folks at Children's Hospital in Boston, are looking at connectivity using MRI imaging in autism and in TSC to see if we can even further better understand the pathogenesis. What we did find, though, is that those with autism also had a significantly higher incidence of cyst-like tubers. We'd been interested in these cyst-like tubers for a few years, and Kat, again, Chu, when she was a fellow, looked back at MRIs of folks with TS and found that 46 had at least one cyst-like tuber. Looking at the presence of these cyst-like tubers, they're much more common in people with TSC2 mutations. They're much more common in younger patients, and we do not see an association with sex. Kat also then looked at what was the relationship of these cyst-like tubers to epilepsy and found that they were significantly more common in those with a history of spasms, significantly more common in those with epilepsy, and also in those with refractory epilepsy. But we're still trying to understand these cyst-like tubers. We don't know if it's a primary or secondary effect. We don't know if there's some relationship to tuber type. And then we also began to see a subgroup of children, I'll show you an image, that have multiple cyst-like tubers, and trying to figure out what the significance of that is. So if you look at this MRI image, these are these cyst-like tubers. You can see they kind of underlie the cortex, so they involve the white matter. And we do not believe that they're true cysts, but there's something about the white matter that's causing this appearance on MRI. So again, significantly associated with both epilepsy and autism and TSC. Adam then also looked at, does the genetic mutation have any impact on autism and TSC? And found, interestingly, that there are fewer TSC1 mutations in the TSC autism group than TSC without autism, suggesting that autism probably is much less common in those with the TSC1 mutation than TSC2. And indeed, we found that TSC2 mutations were extremely common. 90% of our population with autism and TSC had TSC2 mutations versus 60% on our overall TSC population having a TSC2 mutation. We found no significant difference regarding the mutation type or if they were truncating or non-truncating mutations, but we did find a possible relationship of mutations in the Hamerton interaction domain of TSC2, as those were found in 28% of our population with TSC and autism versus 5% without autism. Looking at the correlation of seizures to autism and TSC, we found that those with autism, the history of epilepsy was much more common. History of prior infantile spasms was more common. Earlier age of seizure onset was more common. A greater seizure frequency was more common, and there was a much higher incidence of refractory epilepsy. And we looked at EEG kind of patterns in these individuals and found that there was greater epileptiform features in those with autism, particularly in the left temporal lobe, which had been suggested many years ago by Patrick Bolt in the UK, that the temporal lobes, particularly the left temporal lobe, was somehow very key in autism in this population. Over the past 10 years, my group has spent a lot of time looking at the neuropsychiatric aspects of TSC, which is now referred to as TAND. We found that looking again at our population, about 2/3 of individuals have at least one psychiatric symptom. 37% have greater than one symptom, and the most common are mood disorders, anxiety, ADHD, aggressiveness, and disruptive behaviors. We also did a study looking at our adult population using the SCL-90, which is a validated questionnaire assessing many domains of mental health. And we found that adults are at much greater risk of psychiatric disorders than the general population. And the main difficulties include interpersonal sensitivity, social alienation, depression, and cognitive performance. And then we also looked at self-injurious behavior in TSC, because we even have children as young as 2 to 3 years of age who have pretty significant self-injurious behaviors, found that they're present in 10%, and again, highly associated with a mutation in TSC2, a history of spasms, seizures, cognitive impairment, and autism. And we've been very interested in this anxiety, and now we're trying to really better characterize this anxiety using fancy imaging and everything, because it's not just, oh, you'd be anxious if you had TSC2. It's an anxiety that is really almost like an OCD-ish anxiety that individuals become very obsessively worried about different things. An example I often like to use is I met several years ago a young woman who needed to have heart surgery for a large extracardiac lipoma. She came to see me. We are very proactive now about asking about anxiety and other issues. And she had a very common thing in TS where she had difficulty going to sleep at night because she would replay conversations she'd had not only that day, but even remotely with individuals, worried that she had some, made some miscommunication or would have said something to offend somebody. She also was pathologically worried about contracting AIDS, so much so that sometimes she was unable to leave her house. So I was very interested to see how she handled this hospitalization. So after her surgery, they came back to Boston, and I said, Leah, I was just really curious, knowing how worried you are about AIDS. How was it being in the hospital? And she sat up and she goes, oh, it was fine. The doctors always wore gloves. And so it's kind of like, these anxieties that are so OCD-ish can also be sometimes not completely rational. So anyway, we then have looked at genotype again in the mental health aspects and cognition, and as we've already gone over, TSC2 mutations seem to have a more severe phenotype, but rather than just see it TSC1, TSC2, maybe there is more. As I said, Adam found a relationship between autism spectrum disorders and mutations in the Hamilton interaction domain of TSC2. And then also looking at cognitive phenotype, Agnes van Eegen, when she was working with us, found that protein truncating mutations in TSC2 are associated with a lower IQ, but missense and small in-frame deletions are associated with a higher IQ. Then the location of the missense mutation may also have some impact, as she found that mutations near the Hamilton interaction domain or the gap domain of TSC2 resulted in more significant impairments. So we have spent a lot of time, and a lot of people are spending a lot of time trying to figure out what are the relationships then between tubers, seizures, interictal discharges, the genotype, and is there a role for haploinsufficiency? And I believe that there is, especially with these TAND aspects. And then the relationships of all of these to cognition, the behavioral psychological issues, and autism. So then time to turn to that and just kind of finish up on this possible role of cannabidiol in the treatment of refractory epilepsy. I think that definitely the epilepsy and child neurologists and neurologists in the room know that in spite of all of our new medications and new treatments, the incidence of refractory epilepsy still represents a huge unmet need for effective treatments. And as I said, kind of over the past several years, there's been incredible interest and increasing interest, initially in the United States and now really worldwide, in the possible role of cannabis. So what I'd like to do now is just really quickly look at the history, because I think it's humbling that this is nothing new about this idea. We don't have time to talk about the possible mechanisms of action in the preclinical studies, but then we will turn to what is the clinical data so far in TS of CBD, and what do we need to know. So very humbling to me is that cannabis was actually first mentioned as a possible treatment for epilepsy over 4,000 years ago. in the Sumerian text, and kind of then coming closer in history in the 1100, and even in the 1100s BCE, there are several mentions. In the 1980s, there are actually many published medical reports of the use of cannabis in the treatment of epilepsy, including by William Gowers, who's a very renowned child neurologist. And in 1851, in the U.S. dispensary, cannabis compounds were actually suggested for convulsive disorders and other ailments. However, in 1911, Massachusetts became the first state to outlaw cannabis. Tough for me since I live in a blue state that we were the first state. And this was in the setting of prohibition of alcohol, and very quickly soon after, all of the other states followed. And what really put big hold on this was in 1970, when the United States Controlled Substance Act passed, classifying marijuana and cannabis as a drug with no accepted medical use. Which, as you know, then kind of made it virtually impossible to better characterize its role as possible medical treatment in epilepsy or any disorder. Also made it impossible to conduct basic science research to figure out if it had a possible medical use. However, in 1996, things started changing as California became the first state to legalize medical marijuana. And as I think we all know, by 2015, medical marijuana was legalized in 23 states, regulated at the state level by the state DEA, and CBD was specifically made legal in an additional 16 states. And what's happened over the past several years is increasing anecdotal experience about the efficacy of medical marijuana, especially CBD or cannabidiol, in rich formulations in the treatment of refractory epilepsy. So marijuana is actually an incredibly interesting plant. And I always say, I've always been very interested in this. I've never smoked this stuff, but I've been very interested in it for many years, largely because the cannabinoids it contains. Marijuana has over 500 chemicals. It is the only plant that contains cannabinoids. And I thought this has been really fascinating because our brains contain cannabinoid receptors and we make endocannabinoids. Cannabinoids, there are several in marijuana or cannabis. Cannabidiol is one. It has no psychoactive properties. THC is the psychoactive cannabinoid, but there's several other cannabinoids. So kind of though, is cannabidiol helpful or just reefer madness? And kind of up until recently, all the efficacy data really was anecdotal or open label, and there has been a need for randomized controlled trials. And I think it's really important to say that cannabidiol is not medical marijuana. There's significant variability in the artisanal or vernacular medical marijuana preparations. The FDA has collected several from across the United States that are high CBD, analyzed them, and found no CBD. They've also found pesticides in many of them, as well as heavy metal. So the cannabidiol that I'm talking about is purified cannabidiol. And as I said, cannabidiol is not the only chemical in marijuana. And what about those 5 other chemicals? Could some of them, in combination or alone, be more effective than CBD, or perhaps be more toxic? So I think there's really a need for a reproducible, vetted CBD, a compound that goes through our FDA process of determining safety, tolerability, as well as efficacy. So this comes GW. So several years ago, GW Pharma is a UK-based pharmaceutical company, has been working with cannabis for 25 years. They have another product that's licensed in 33 countries in trials in the United States called Sativex. It's 50% THC, 50% CBD for MS-related spasticity. And they had a lot of preclinical data of efficacy of CBD in animal models of epilepsy. So several years ago, 5 of us got together, the Mass Journal and several other academic sites, to talk to GW. And together we decided to file for an expanded access program, IND, to the FDA, allowing each site to put 25 patients with refractory epilepsy on CBD. And reports of some of this were recently published in Lancet Neurology. We had an initial 25 we enrolled. The DEA and FDA then gave us permission to enroll another 25. Our first 25 started in April of 2014, so we have children who have been on this medication now for 2.5 years. And following the expanded access program, GW then initiated studies in Dravet for an indication in Dravet. They have 2 randomized controlled trials. The results from the first trial are released and were positive, and then 2 trials in Lennox-Gastaut syndrome. Both of those studies are completed, and the results of both have been released, and also both studies were positive. And then based on the data I'm going to show you from our experience in the IND with TSC, they also filed for an indication for tuberous sclerosis complex, and that randomized controlled trial is now enrolling. So in the expanded access program, these were children with super refractory epilepsy, and the 5 initial sites actually wrote biographies on each of the 25 patients saying how old they were, how long they'd have epilepsy, how many medications they'd been on. Most of these kids had been on numerous medications. Most of them had had epilepsy surgery. Many of them had been on diet. Many of them had vagus nerve stimulator, and most of them were still having multiple daily seizures. So a biography on each one going to the FDA saying why we felt these children needed the opportunity to see if this could be a safe and effective medication. And all the programs used a similar, if this was not a trial, it was all open label, we used a similar scheme for initiating so we can compare the data. So initially starting at 5 mg per kg, titrating up to initial 25 milligrams per kilogram per day. And we tried to run it like a trial without changing other treatments during the first 16 weeks of treatment. At our site, we also did neuropsychological testing pre and during the trial, as well as EEG. And we've just not had a chance to analyze any of that data yet. So of the 56 kids that we put in our IND, 18 had epilepsy due to TSC. You can see that there's a pretty broad age range, but most of them were children. And range in seizure onset, the majority had a history of spasms, and then various mutations leading them to have TSC. This is a complicated slide, but the purpose of this slide is these are all the individuals that we had in the IND. This kind of the number of medications when they started, so most of these kids were on numerous medications. As I said, many of them had had epilepsy surgery, had the VNS, or were on diet. Many of them had mixed seizure types and a pretty high seizure burden, baseline seizures over the month ranging up to 100 seizures, 200 seizures during the month. And what we found that we were really encouraged by was 50% of these kids, 9 of the 18 were responders, having a greater than 50% reduction in seizures, some with a pretty dramatic response. And then what we also found, and this is what's really subject to bias, including on my part since it was open label, but all of these parents reported cognitive gains, particularly improved alertness, verbal capacity, communication, vocalizations, cognitive availability, and the initiation of emotional and physical connections. And that included 9 non-responders. So an effect that was possibly independent of seizure control. This takes a look at what happened with seizures and different seizure types. So these graphs, basically, each of the different lines represents an individual patient. The lines are different lengths because the children had been on the medication for varying amounts of time. The 0 is their baseline seizure frequency. So any that go below 0, that shows a reduction in seizures. Any above 0, an increase. And as you can see, if you look at total seizures, there is a fairly dramatic decrease in many of the patients. If you break it down to seizure types, looking at focal dyscognitive, again, many children had a significant reduction in seizure activity. Similarly for atonic seizures and for tonic seizures. A group I was particularly interested in is spasms. And in addition to the TS kids, I had a total of 10 children in our IND with a history of spasms, highly refractory spasms, all epileptic spasms by this point. And impressively, all of the kids had a reduction, usually a cessation of their spasms. So GW is also now looking at this as a possible treatment for infantile spasms. Side effect-wise, 3 of the 18 had diarrhea. The medications in a sesame oil, so with increasing volumes, it resulted in diarrhea. Many of the parents found this to be a positive side effect because some of these kids were on pretty incredible bowel regimens due to constipation. We did learn there can be significant drug interactions due to the hepatic metabolism, particularly with clobazam, because clobazam has an active metabolite called desmethylclobazam, which can be significantly elevated by CBD. And that results in often profound drowsiness and irritability. And then we initially went up to 25 milligrams per kilogram per day. The DEA then let us double the dose in those that were tolerating and not yet seizure-free, and found that there is quite a dose range that these kids can have experience efficacy. We did have 3 children exit the study of the 18. The other 15 continue on CBD. The third case exited due to diarrhea and weight loss is an adolescent from New Jersey who's going to be undergoing epilepsy surgery in the near future. Case 4 had significant weight loss, and at first we weren't sure because this is one of the things we were keeping an eye on with CBD, the resultant weight loss. We then determined that he had a viral myocarditis unrelated to the CBD, and his mother would like him to restart drug as soon as his blood pressure normalizes from that. And then case 10 exited after having epilepsy surgery. When he was in for his surgery, I walked in, I said to this kid and his mom, I said, gosh, I'm so sorry this didn't help. It just seemed to be helpful for other people. And the mother looked at me and said, what are you talking about? He hasn't had a generalized tonic-clonic seizure since he started this. And he was a young man who had nocturnal focal seizures, but was having an escalation of generalized tonic-clonic seizures, which is why he entered the CBD trial, nailed the tonic-clonic seizures, but he was continuing to have the focal seizures. So he's now been seizure-free after epilepsy surgery. So just to quickly tell you about a couple of these kids, case 1 was a 14-year-old male, TSC1 mutation. He had seizure onset at 5 years of age with complex partial seizures. He had been treated with 9 medications, had the VNS, and had epilepsy surgery. On 2 medications when he started CBD, and he experienced a 63% reduction in seizures and behavioral improvement. Case 5 is a 13-year-old girl, TSC2 mutation, intellectual disability, and autism. She had onset of seizures at 3 months of age, focal dyscognitive seizures and subsequent spasms. Before going on CBD, she'd been on 7 medications, had epilepsy surgery, had the vagus nerve stimulation, and at treatment onset, she had focal dyscognitive, focal with secondary generalization, on 3 medications and with the VNS. Overall, she had a 40% seizure reduction initially, so not a responder. But her parents described cognitive improvements, including vocalizations and cognitive availability. And although it could be bias on the parents' part, the school also noted significant improvements in this kid to where they had to revise her IEP a few times. And for the first time, mother of this family knows that their daughter knows how to identify her colors. Her mother says now she's much more work than she used to be. And then case 9 is a 9-year-old female, TSC2 ADHD. She had infantile spasm onset at 1 month of age. She'd been on 6 medications, had epilepsy surgery, had the VNS. At treatment onset, she had a mixture of seizure types, including extremely frequent atypical absence seizures on 3 medications of the VNS. She's been completely seizure-free. And she's also cognitively improved. Before she went on this, she was having really almost constant atypical absence seizures. Her brother said to me, you have to help her, we've lost her. And now she is almost nonstop talking. Her mother describes her as Chatty Cathy. So this just leads then to the ongoing trial, the 1521 GW Pharma trial, which is to evaluate the efficacy of Epidiolex or CBD as an add-on therapy in reducing the frequency of seizures when compared to placebo. It's broad age range, both children and adults with refractory epilepsy with TSC, and this is going to be conducted at 38 sites in the United States, Australia, the Netherlands, Poland, Spain, and the UK. And this just quickly looks at the trial design. After a baseline period, there's a titration. The design is 1/3 will be on placebo, 1/3 will be on lower dose, 1/3 will be on higher dose. And after titrating up, a 12-week stable treatment phase until everyone can roll over into the open label trial. So I'm very excited to see what happens, and if it does prove to show that or turn out that the efficacy we've seen in the IND experience with TSC, refractory epilepsy CBD, holds true with this. So again, then just to finish, again, what a lot of people are thinking about, Pete, Mike, me, and many other people, is what is the relationship and what can we learn about the neuroanatomic changes in the brain and neurophysiologic changes in the brain, as well as genetic changes that may lead these individuals to have cognitional issues, behavioral issues, and autism. And then I just really need to thank the Herscot Center, and I'm really excited when I was here a few weeks ago to talk to Fatima and Jules, and we're really looking forward to working closely and hopefully playing with different research projects with you guys. But it really has become a broad multidisciplinary program at the MGH. So I'm very thankful to these people and the families we take care of. So thank you very much.
Thank you, Elizabeth. We have some time for questions from the audience. Just a quick one. From the TSC cohort, the CBD trial that you do you think that you'll be able to compare whether there is more vigabatrin-treated patients in the responders versus non-responders? And I'm saying that because of a study that was published in Epilepsy Open that CBD may actually affect GABA receptor signaling, and this is a primary disease to be sensitive to this mechanism?
We will absolutely be able to do that. I mean, because all the kids going in these trials are on concurrent medications, and so we'll be able to look at was there any particular combination. In addition, the older kids are on the trial who had spasms. I'm assuming most of them were on vigabatrin, so we could kind of compare kind of vigabatrin responders to non-responders and how they respond to CBD. So both concurrently being treated with vigabatrin as well as remotely being treated with vigabatrin, we'll be able to do that.
Steve?
Elizabeth, thank you. Can you comment, and Pete, Mike may want to comment as well, about links between the ketogenic diet and mTOR activation? Do we know anything there?
Mike, are you going to talk about that? So it apparently is when Pete showed kind of the nutrient modulation of the mTOR pathway. So when that was first identified, there was a lot of interest in then would the ketogenic diet be a possible treatment for TSC? And we looked at that clinically. Ray Young looked at that. Mike did some work on that. And maybe you can address what you found. Clinically, we didn't see, didn't do long enough follow-up. And we kind of did try and say, gee, if we've had kids on the ketogenic diet, what happens with other organ involvement? Very small N. If anything, in that very small N, there seemed to be more prominent other organ involvement. But I don't know. I think it was just too small of a number to conclude anything.
But has it been looked at like in rodent models or where you could actually look for mTOR activation?
Yes.
It's been shown that ketogenic diet can inhibit the mTOR pathway. Beyond that, it's not much.
But there's a huge amount of interest in that. Which is one of the reasons when we know that the ketogenic diet can be wicked effective in treating seizures. And we also have a lot of experience now starting the ketogenic diet in children while their mothers continue nursing. So that's one of the reasons we were really interested in doing our prophylactic trial, the use of diet therapy in babies known to have TS before seizures start.
Thank you so much, Dr. Thiele. So I'm just wondering, so the cannabidiol is a sesame oil formulation. And based on the dosing that you're talking about significantly increasing the oil calorie intake in these patients. I'm just wondering, you're sort of pushing them in the spectrum of what you talked about in your ketogenic diet or low glycemic diet in terms of the percentage of their diet that is oil. How much do you think that's going to impact when you're looking at the placebo group in this clinical trial?
No, because even though it's oil, we're not really modifying their diet in any way. It's just like taking a liquid medication, and that ends up being, for most of these kids, it ends up maybe being a teaspoon or two twice a day. So it's not a huge volume of oil. It's just enough to have a laxative effect, in some of the kids because it's more oil than they typically have in their diet. But the control group is getting the same sesame oil, just without the CBD, so we'll be able to, balance that out.
Great. Thank you very
Thank
much,
you.
Elizabeth. Thank you.